Hello, everyone. Let me introduce my 3-month progress in my projects thus far, revolving around the topic of biopsies in radiology. My name is Teodóra Filipov. I am a PhD student at the Department of Interventional Radiology at Semmelweis University. My supervisor is Pál Ákos. My vision is to be able to lower patient discomfort in a hospital or outpatient setting by offering non-invasive, minimally invasive, and less invasive diagnostic tools and interventions. And my mission is to research novel interventions and diagnostic methods to be able to reach this goal. And also, my 2 projects this year are probably going to help me reaching my goal. Both of them are meta-analysis. The first one is in the topic of kidney transplantation. The title you can see up there, Elastography compared to biopsy in the evaluation of kidney allograft dysfunction. Kidney transplantation is the most effective treatment for end-stage renal disease, but 25% of recipients present symptoms of allograft injury within the first year. The gold standard to this day to detect changes in the kidney is a biopsy, but it is limited by its invasiveness and a small sampling size. A new promising modality is elastography. With its non-invasive nature, it may be able to help in detecting allograft dysfunction. We want to assess if there is a correlation between elastography findings and allograft dysfunction parameters. Our primary outcome is a fibrosis detected by biopsy, and we also will assess secondary outcomes measured by laboratory results and Doppler ultrasounds. And of course, the most important part of this research is to find a non-invasive way to detect dysfunction. We have conducted a search in October with the search key above, and this is the flowchart of our selection. Right now we are in the data extraction phase. We want to finish that this week or maybe next week, by the end of next week. My second project is about thyroid nodules, the effect of needle gauge and technique on the success rates of fine needle biopsies of the thyroid is our title. Thyroid nodules are pretty common findings in the general population, especially above 50. And 10% of these nodules may harbor malignancies. With the application of ultrasound-guided biopsies, the management of these nodules has become more manageable, but still the percent of non-diagnostic cytopathology at biopsies is 10%. And this can be due to the nature, the parameters of the nodules, but also wrong technique and wrong needle caliber can also yield non-diagnostic results. And according to guidelines, a repeat biopsy is needed in these cases, of course. So, with optimal needle caliber coupled with adequate technique, it would be possible to lower the percentage of non-diagnostic results resulting in earlier diagnosis of malignancies and lowering unnecessary patient discomfort and anxiety and also medical costs. And our aim is to assess the variables influencing thyroid fine needle sampling. We are going to have 2 picos, one for the needle diameters and one for the technique that is used in these studies. And yes, our clinical implication is, as I mentioned before, to lower patient discomfort and medical costs of repeat biopsies. We have conducted a preliminary search with promising results, and we have started Prospero registration. Actually, yes, this is a figure of our network of the needle gauges. These are the studies that we have found thus far, and yes, of course, after the Prospero registration, we can start the systematic search. Imagine that there is an overview slide here. We want to submit these projects by summer of next year, and as you saw, the most important for me is to be more patient-oriented. As William Osler said, the good physician treats the disease, the great physician treats the patient who has the disease. Thank you for your attention.
I'd like to ask you, how different is the pain felt by the patient depending on the diameter of the needle used?
Of course, a bigger diameter of needle results in bigger pain, yes. So basically, that is the basis of this.
And for the smaller ones, you wouldn't use local anesthesia, and for the bigger ones, you would?
Well, there are studies with different methods. Most of them don't use local anesthesia in these settings, but of course you could use that, but that is also, of course, another needle stitch and another source of pain, initial pain.
Is there a guideline for this consensus? Or just everybody uses what he or she thinks?
Well, yes, especially here, we know in Hungary that most of these things are based on personal preference, and everyone does it in a different way, even in one clinic. So it is pretty diverse.